Welcome to the SRPC COVID curriculum. This is video 1 of 4. In this video, we're going to talk a little bit about the COVID curriculum, aerosol generating medical procedures, and titration of oxygenation. In this series of 4 videos, we're going to be walking through a stepwise approach to oxygenation and airway management of the suspected or confirmed COVID-19 patient. We're going to be talking about a lot of oxygenation equipment. If you don't have this equipment in your ED, don't worry about it. If you have it, great. If you don't, use what you have. Some EDs have made some developments, such as producing weight-based grab bags or checklists to make the equipment gathering phase of resuscitation more efficient. This is something your ED could consider, especially with limited personnel and a goal of decreasing ED exposure to COVID. We're going to start by talking about aerosolization and AGMPs. So the general consensus is that if you have a negative pressure room, your COVID patient should go in there. Aside from that, a sufficient amount of the evidence is actually quite mixed. The risk to you and your team should be thought more of as a gradient as opposed to black and white. With increasing intervention, there's higher risk, but we still have the duty to take care of the patient. At the end of the day, the risk for contracting COVID is impossible to completely eliminate. Your goal should be to get so comfortable with the resuscitation of a COVID-19 patient that you could focus more on what will keep you safe, specifically proper PPE use. One of the best ways to do this is to use a checklist-based system and have observed donning and doffing of PPE. Let's talk about O2 titration. Really, where you start on this pathway is based upon your clinical suspicion of how much time you have. If you've got some time, it's worth titrating up your O2 slowly, because this not only serves to decrease the risk of aerosolization, but also helps you to pre-oxygenate in case you do need to intubate the patient. The place to start is with nasal prongs, up to 6 liters. Once you've surpassed the need of 6 liters by nasal prongs, you can move to a Tavish mask or a Hyax mask if you have access to them. Or just throw a non-rebreather over the nasal prongs. You can put the non-rebreather up to 15 liters. Now, at this point, you've probably heard a lot about proning. Proning works in a few ways. It takes the weight of the abdomen off the lower lungs, and it also equalizes mechanics within the lung, so that hyperdistended alveoli become less distended, and collapsed alveoli open up. This serves to decrease the shunt physiology in COVID. Many patients actually don't tolerate the prone position for long, so you can't actually allow your patients to switch position, rather than solely maintaining the prone positioning. The important thing to know about proning is that this is a transient improvement. So while there have been studies that show marked improvement of oxygenation after a patient is proned, keep in mind that proning only buys you time. It is not a permanent solution. Once you surpass the nasal prongs and non-rebreather with proning, you're going to be moving up to PEEP. So PEEP is going to help you open up those alveoli and help physiologic optimization. The problem with this, though, is that based on your center, most centers will not accept transfers with any amount of positive pressure unless they're intubated. So once you're needing to move to PEEP, you should think about whether or not you're going to intubate this patient. Talk to your referral center and figure out what they'll accept. While regular CPAP and BiPAP are options, the concern with these methods of PEEP delivery is really the volume of oxygen that is transferred to these patients. There are options to provide low-flow CPAP, and we'll talk about that in a following video. If you are needing to give a patient positive pressure, remember your anxiolytic. This is really a patient where you don't want to have them pulling off their mask. If you're lucky enough to have high-flow nasal cannula, you can think about that as well. And so at this stage, you should really be thinking about having a serious goals of care discussion with your patient. COVID is unique from the things that we've seen before, so here are a few COVID-specific things to think about when having these discussions. In most centers, patients who need positive pressure will need to be intubated for transfer. There have been many studies done about this, and they found that any positive pressure often leads to an average of anywhere from 10 to 14 days of requirement of that positive pressure. So whether it's CPAP or BiPAP or intubation, they're signing themselves up for a long hospital stay. Mortality studies that have been done have been highly variable. In the peak early days of COVID, we were seeing survivorship rates of 1%. Conversely, in some places, they're seeing mortality rates of only 10%. I think at this point, we don't really have a true gauge of mortality, but the patient needs to know that their risk of dying is exceptionally high. Observational studies have shown a 2 to 6% risk of peri-intubation arrest in these patients. Often, well-meaning hospital policy means that these patients will die alone and will say their final goodbyes to their families via video conference. However, keep in mind that an endotracheal tube is not necessarily a death sentence. If you feel that this patient might need an intubation, it's more important to recognize that early so you have time to prepare for the intubation as opposed to putting it off and dealing with a crash intubation. So to recap this video, use what you have in your department. You might not have all these fancy bells and whistles. Think about producing a set of grab bags or checklists for your emergency department. They're really good at decreasing cognitive load and preventing you from forgetting stuff when you walk into the room. Despite all the deliberation around aerosolization, the reality is it's a gradient, and increasing intervention means increasing risk. Balance that with the needs of the patient. Remember that proning is a transient way to buy time and not a permanent solution, and that the logistics of adding positive pressure is a center-based decision. Intubation is associated with high risk of morbidity or mortality, but it's not you intubating the patient that causes that. It's the underlying physiology that does. If the patient needs an intubation, recognize that early and avoid the crash intubation. This has been part 1 of the SRPC COVID airway curriculum. We'll see you in part 2.